I don't think the fear of getting bitten should prevent people from enjoying the outdoors and getting out in nature. I think what you said earlier, building up the immune strength, building up the digestive health, building up just resiliency it's the way to go.
Hey everyone, today I spoke with Dr. Amy Offutt, who is a wealth of knowledge in integrative medicine with a focus on chronic infections. And for those of you who are doing many of the important foundational practices of diet, lifestyle, gut health, but still noticing chronic symptoms, maybe there's brain fog or fatigue or anxiety or depression or joint pain, what have you. There's a decently high probability that a chronic infection could be what is causing this lack of full responsiveness to these other things that tend to help a majority of people. And this is why I hope you will take a lot from this conversation about steps you can take to sort out what might be the root cause of these lingering symptoms. And I want to leave you with a quote from Helen Keller. Optimism is the faith that leads to achievement. And I'm hoping this conversation gives you the optimism to keep on your journey to make sure that you achieve optimal health. Because there's no reason, if you're willing to work, that you can't grasp and achieve that goal. So now we will go to the conversation with Dr. Amy Offutt. Hey everyone, I am here with Dr. Amy Offutt. Amy, welcome to the show.
Thank you. Thanks for the invitation.
Yeah, your name came up a few times. First by Kyle Kingsbury, a friend of mine, who has been in your clinic, which is outside of Austin. And then you were at the TFIM speaking when we were doing some research on various conferences. So I think we were meant to have a conversation, and you do a lot in integrative medicine. But the thing I really wanted to kind of double click on, one of your areas of specialty, is chronic infections, Lyme, and sort of, the cohorts that hang out with Lyme. How did you start with working with Lyme and chronic infections?
So I'll try to make it short, even though I could give you a long story. I was actually already attending some integrative medicine classes. And I even remember it specifically, I was listening to one of my favorite lectures in a functional medicine course on autoimmune diseases. And it was a Sunday morning. It was in Washington, D.C. And the lecturer said, "You're in for a treat today. Today I'm going to teach you about Lyme disease." And I even remember thinking I was disappointed because we don't have that in Texas. And so, I mean, at least that's what I thought at the time. That was probably in 2010. And he was very quick to start asking us, do we have patients who just don't respond to the usual therapies? Do we notice that, patients with headaches that don't resolve with the standard medical approach or even an integrative medicine standard approach? And of course we do. We're all at this meeting because we're all there to learn more tools for our toolbox. So I came home that day. And in fact, that day I wrote down the names of several of my patients that just his lectures made me think of. And at that time, the way he was approaching it was he was drawing 2 immune markers and 1 inflammatory marker. And he said, if these markers were out of range, then the patient has a chronic infection. You just have to go look for it. So literally all the patients I wrote down that afternoon, I came back to the office. I handed a list to my nurse and I said, call all these patients and have them each come do these labs. Every single one of them had the pattern that he described. And so the problem was all he gave us as treatment at that time was like pulsed antibiotics, which, as you know, about a third of the patients said, okay, I'll try it. And I think some of them did respond positively, but about a third said, no way, I'm not doing that. I don't want to take antibiotics. And about a third of them tried them and just couldn't tolerate them at all. So then I was left with, okay, now I know there's something wrong, but I have no other approach.
Tools.
So that's when I started going to ILADS meetings, which it's the International Lyme and Associated Diseases Society. And I actually got sucked into that organization, and I learned so much from going to those meetings that I eventually ended up getting asked to be on the board, and I'm actually the board president for iLads right now. So
Awesome.
it's a nonprofit. We have about 600 members. I would say a lot of us are integrative. There are some more traditional physicians and clinicians in the group, but the whole mission of the organization is to educate more doctors out there about how to approach patients who maybe aren't getting the deep dive that they need to get better. That's kind of
Yeah.
the
So
foundation of
important.
most integrated medicine.
Yeah. Yeah. I mean, so important. And I love your story. It reminds me of, just last week, we had this case wherein you have digestive symptoms, bloating, loose bowels, abdominal pain. Then you also have insomnia, brain fog, and joint pain. And a lot of times those symptoms, those non-GI symptoms, are driven by what's going on in the gut. But to your point, with this patient, we tried all the therapeutics that work for most people. And time again, we're just swinging and missing. And so I said, this sounds like it might be a chronic non-GI infection. And we put her on a herbal protocol, including artemisinin, which is an herb I'm just having this increasing interest in. It just, for some people, is so powerful. And followed up a month later, and she said, "Can I keep taking the artemisinin? Because I'm feeling so good on it." It was the first time in over 6 months that she really saw notable improvement in most of her symptoms. And so for the people in our audience, I really want to put this on everyone's radar screen to think about if you've done a low FODMAP diet, an elimination diet, probiotics, maybe a reset with an elemental diet, the gut therapeutics, and you've seen a flicker of improvement, but you haven't really seen full improvement. This is an area I think we should be paying attention to. And Amy, I thought how we could start is maybe going through some of the more common symptoms. There's a lot, right? One of the challenges with many various syndromes, if you will, is such a broad presentation. But maybe we can try to pick through some of these and sort of list the symptom and then what's going on in the body, so people might be able to sort of personify some of this and get a sense for, is this me? Fatigue is certainly one. These chronic infections can lead to different names, different mechanisms. One of the ways I like thinking about it is sickness behavior, where there's this chronic inflammatory response, almost like you have the flu, but without all the respiratory involvement. You just feel kind of blah. How do you
Exactly.
think about fatigue? I mean, it's a pretty obvious one, but what are your thoughts regarding fatigue and chronic infections?
So earlier you mentioned the TFIM talk. I actually talked about microvascular changes that are caused by chronic infections. That was the
Yes,
topic
I listened to
that
that.
I
It was great,
covered.
by the way. Yeah, yeah.
And I mean, it's such a huge topic to unpack in a lecture, but I tried to specifically pull from the medical literature what I could about the effect that Borrelia, for instance, has on the microvascular. It's really where all the immune um, imbalances happen. It's really at that location in the body, which is really everywhere. So that's why you have so many different presentations. So many patients think they have Lyme, and some of them don't actually have Lyme, but they might have Bartonella, or they might have Babesia, or they might have a chronic viral issue. And all of those are triggering some inappropriate immune response, or maybe it's appropriate, honestly. But then their body cannot, overcome whatever it is. So trying to help, even helping them improve blood flow can help with fatigue specifically. But I find fatigue is very challenging to treat, but I usually, even with my patients who I think have chronic infections, I'll start talking to them about the basics, and a lot of them don't sleep enough, and that's why they're so tired. But they don't sleep because they're
Are they
not
pathogen?
in, yeah, they are in fight or flight because they're infected, and that puts them in at a disadvantage with being able to rest. So, and then as you know, like gut health is at the core, no pun intended, of everything that is immune. And so, um, what they eat, what they don't eat, what they've taken, what they're going to take, what they can take and not have symptoms from. I mean, it's a puzzle, but I like to tell the patients, each patient is going to get a very individualized, personalized approach. And this may seem like a little bit of a silly analogy, but it's like we get on a boat and we have the same destination, which is health and wellness or vitality. But the course that we take across the ocean is different for each person because of, weather, water, just no two people have the same protocol because
Right.
we have to be flexible to the way that each person responds. But I love it when people say their fatigue is better. I think one of the biggest challenges is actually having a measuring stick for a lot of these symptoms. Like, I think that's one of the things that's wrong with a lot of the research is we're looking for these numeric outcomes. And for me, the outcomes I'm looking for are less easy to measure.
Yeah.
If someone goes for a 5-mile hike and they haven't done that in 8 years and they come to the office and say, "Oh, Dr. Amy, I'm so happy I was able to hike and I didn't have to pay it back and stay in bed for a week. I actually got up the next day and
Yeah.
still felt okay." I that's how I know we're on the right regimen. And
Yeah.
but that's really hard to measure if if you want to publish it or you want to put it together in a clinical informative
Sure.
collection of data. And so we're always talking about how could we do that. And we do have, even in iLads, we had a nice a lead donor put forward some funds to do. We've called it the Big Data Project, but it's really it's an international effort. We have some European doctors as well that are trying to help us figure out a way to use some of the newer technology to take clinical data from multiple clinical sites and put it together for patients who are getting treated for chronic infections.
I love
So
it.
hopefully that'll actually.
Yeah. Yeah. I mean, one of the ways, and I agree, it can be challenging. And we tried this a while back with an IBS symptom severity. This is for gut patients, but there is for IBS some nice symptom inventories available. The IBS SSS or symptom severity score is 1. And we were trying to pair that with a PROMIS 10, which is quality of life, and then repeat over, serial assessments. We just had really bad automation and systems. And so that we crashed and burned, but we learned. And now we're trying again, and we're going to sort of use some of the elements of Horowitz's symptom inventory for Lyme and Lyme co-infections and pair that with a PROMIS 10 and see if we can get a signal pre-post that sort of tends to correlate with treatment response via a quantifiable measure. But you're right, it is challenging, but I do think we need better because we can't just operate under these sort of ethereal, well, I feel better. I mean, that's nice. And as a clinician, I think that's what we really care about. But if we want Lyme to go from this gray area, well, chronic Lyme doesn't exist, therefore you don't have to treat it. We need some more, peer-reviewed inventory or better quality data that we can at least show, well, maybe you don't agree with chronic Lyme, but look at this data. We took a cohort of 30 people and their pre-post, PROMIS 10 scores improved by 40% on average, something like that. That's what I'm hoping. So it sounds like we should probably chat afterward too about maybe some research because I share your passion there. You mentioned insomnia. This is another one that, I think about cognitive behavioral therapy as something which has been shown to be helpful for insomnia. Yes. But I also wonder if some people are getting shoehorned into all these lifestyle modifications that they may not need. And I'm sure, because I've suffered with this myself, there are people who are doing all the things right. Dimming the lights before bed, reading, relaxation, no caffeine afternoon, eating enough. And, they feel good about their checklist. Then they go to sleep or try to, and I can't sleep. That's been me. And so for those of you out there, again, I'm sure some in the audience have suffered with this. This seems to be a big one, especially, and correct me if you have any disagreement or nuances on this, but Bartonella, is that one of the more common presentations for Bartonella? Is impairments in sleep?
I definitely think I think it is the fight or flight. Like
Yeah.
if the body is like a little adrenalinized because, anxiety is one of the biggest symptoms of Bartonella that I see in my practice.
Mm,
And that just translates into, you know, um middle of the night, easy awakening, light sleep, poorly restorative sleep. So I mean, I like again, like the whole integrative medicine approach, I think one of the things that frustrates me is that I think we have integrative physicians out there who hate everything conventional. And then we have conventional physicians out there who hate everything integrative. And if we
agreed.
just quit doing that and started looking together at like what do we need to do for this patient in front of us? Because sometimes we do need to even sort of snow them under for a few nights rest. Not forever. I mean, I'm not a big fan of sedative hypnotic insomnia medications. I don't really use those. I have found other things to be more helpful, but sometimes I do use some prescription medicines to restore sort of a routine or a wake sleep cycle, or, get somebody back, to even feeling like they can sleep. I find it's almost traumatic. Like the people believe themselves into it. Like I'm not a good sleeper. Like when people say that, I'm like, oh, and I mean, I'm guilty too. I'll wake up at 1 thinking about, a patient or one of my kids, or, a lot of times mine, I call it my busy mind, and I'm so happy when I wake up in the morning and I didn't wake up that night.
Same. Yeah.
But,
I'm with you.
good sleep is just so critical to getting better. And so I'll do anything. I don't start with the heavy duty things to get people to sleep. I start with all those things you mentioned, and kind of more of a herbal approach. And then when we start really treating the right thing, I find they do sleep better. So whether no matter the therapeutic is, if we're on the right track, their sleep. I actually have tried using, I call it an inflammation score tracker. It tracks sleep, cognition, mood, energy, and pain, because to me those are the big 5 categories. I mean, I just made it myself. It's like a little spreadsheet. I wish I could make it an app. I have a patient who said she might do that for me. But like, so that, because I think, like, I love the MSIDS questionnaire from Dr. Horowitz, and it's a validated questionnaire, but it's just so lengthy. Like for patients to look at 38 different symptoms. And I like what you said, that you could take a portion of it. But even with my inflammation score tracker attempts, in fact, I was talking with another doctor about it the other day. He has his nurses fill that out every time the patient comes into the office, like a vital sign. I
I
kind of
love
like
it.
that.
Yeah.
So I think I'm going to incorporate that. I'm going to steal it from him. Because I've been trying to get patients to do it, and they don't feel well. So they have a hard
They're
time being
tired. Yeah.
consistent.
I get it.
Hmm.
I get it. By the way, if this has been helpful, please subscribe, comment, and share this with one person you think it might help. And so another thing, I think we touched on this to some extent, but brain fog, neurological symptoms at large, anxiety, even bloodshot eyes. And one of the things I found interesting about your TFIM presentation was really how you unpacked how your microvasculature can be damaged. And in part, what these bugs can do is make your blood more viscous. And so you can't get
Hmm.
circulation to the eyes, the brain, the gut. I even found one study that found about 50% of people with Lyme had either low libido or erectile dysfunction, thinking about another area where circulation is really important. So this is something that um, I think is interesting and important that we talk about. Part of these problems might ultimately be due to circulation and how these bugs can throw off things like your heparin levels and lower those.
I agree. I think when, um, you know, like if you've ever looked at some of Bob Mosiani's work, he has a lady that works with him who's got some beautiful electron microscopy photographs of
Mm,
some of the microvascular biofilms from these organisms, specifically Bartonella. And if you could imagine that being present in a large part of the circulation, I mean, we kind of focus in the US, I think, on the microvascular circulation with regard to cardiac health.
mm,
There's a lot more information on that particular organ than, say, there's some on the kidney, but the brain and the heart seem to be the two big areas that we focus on the most, because
Right.
that's where most of the healthcare dollars are consumed. But I think a lot of patients who develop dementia or heart disease probably have a chronic infection that's creating chronic inflammation on the microvascular level. And it's a slow, chronic, steady process. It doesn't just suddenly happen one day that someone has, a plaque rupture, I don't think. But
Right.
that's, that's not necessarily made it to the mainstream medical mindset just yet.
Sure. Sure. Another symptom I think is important to put out there is joint pain and muscle pain. In fact, I heard someone describe this or recommend clinicians be a little more attentive when someone says they have, let's say, low back pain. And it's possible that low back pain or maybe chronic shin pain may not truly be musculoskeletal in etiology, but rather because some of these organisms hang out in the joints, hang out in the bone marrow. You can be the person who's always needing therapy. I do PT and then I do OT and then I do knees over toes. And, you never kind of feel like you get a real grasp on the pain. And it might be due to infections here also.
I agree. So my husband is a myofascial pain therapist. So he sees people and, for lack of a better way of describing it, he finds some of those areas where there's constriction or a lack of blood flow, and he has several different techniques he's learned. So we refer patients back and forth to each other. But I've had some patients that I had a hard time improving their pain, and then I'll have him see them. And it's interesting. He has very good hands and a very good feel for, each person's pain. And he notices, he'll say to me, I think this patient has an infection, and tell them to come downstairs, because he almost can palpate a different type of
Interesting.
myofascial, I think it's
Yeah.
subtle. I don't necessarily perceive it. I'm pretty good at finding trigger points, but I don't perceive, he describes it almost like a doughy texture. And of course, what makes people come in the first place is their knee hurts or their back hurts or their shoulder hurts. And he doesn't do that with everyone. If it's someone that, maybe they've just been playing too much pickleball, he'll just work on their arm,
Right.
and help their arm. But if they have migratory pain or like recurring pain that gets better and comes back,
Yeah.
a lot of times we'll do the workup and we find that there is something else there that's causing the pain too.
That must be really fun to kind of be able to go back and forth from the two different perspectives, musculoskeletal and more internal. That's cool. Something else, curious how much of this you see with Babesia, apparently non-hormonal hot flashes. This is something at the clinic I've been trying to do a better job of making a note. Is this a female 28 years old with hot flashes, or is it a man with hot flashes for no known reason? Not, sometimes I have a flare of anxiety and then I have a hot flash. Okay, we can maybe put that aside. But if there's no hormonal or other sort of anxiolytic induction, this is another potential symptom. Do you see much of this?
Definitely. Like, since you're talking about symptoms particular to certain infections, there are a lot that do overlap, but there's some very specific ones. And the sweats or fevers, like tick-borne relapsing fever, is really a borrelial disease as well. It's just species that are not the more conventional Borrelia burgdorferi species. And they're often carried by soft ticks instead of hard ticks, which have different behaviors in nature. They can crawl out of a tight space in a cabin. I actually even have a family that had bats in their chimney in Houston, in a really nice neighborhood, who all were bitten by soft ticks and all developed TBRF, which, the way that manifests is more of a cyclical, once a week, every 10 days, more of like a flu-like illness, like you described sort of at the beginning of this conversation, with some fevers, with some, like, people just don't know to think that they could have been bitten. So many people don't remember being bitten by a tick, but certainly with Babesia, patients will have, it's hard to take a deep breath. Some people call it air hunger. That's somewhat specific to Babesia. Different than anxiety or different than I can't breathe, more of a, I can't take a full breath. They become less exercise tolerant. I used to be able to walk up the stairs. Now, when I walk up the stairs, I have a harder time breathing. And they have sweats. So when
Yeah.
I hear that they have sweats, as I'm sure you encounter, some patients don't have a lot of resources to do a lot of tests. And I'd love to do tests as much as I can for, more information. But if we do take a really careful symptom inventory, sometimes we can piece apart like what they most likely have
Right.
and then start to treat it and see how they respond as a way to approach their case. So
Yeah. No, you're preaching the choir on that. Um, what about a feeling of incoordination? This is something else that I think is kind of an interesting symptom. Um, how often do you see that, and what do you think is going on in terms of why people present that way, a little bit off balance?
I would suspect that's probably again like the blood flow issue, the microvascular circulation, that where they're noticing an issue is probably affecting their vestibular system,
Hmm.
um, or or even their inner ear,
Right.
and or their vision. So many people, like when I start to work someone up for a disequilibrium, I kind of think top down. Brain, eyes, ears, spinal cord, peripheral nerves, muscles, like reflexes, position sense, and like if any of or all of those are an issue that can be addressed. Like, I mean, it's very complicated, but at the same time, it's a very common symptom. So many people do feel, they'll use the word dizzy. I
Right.
don't usually find it to be vertigo. It's more of just a disequilibrium, or they feel like they're falling when they're not falling.
Yeah.
I hear that a
So it's
lot too.
not
And a
like
lot of,
I'm seated and I get up and I feel dizzy. It's more of a global dizziness that's kind of always there to some extent.
well, a lot of patients come and say they have POTS, or they've been diagnosed with POTS,
Mm.
or they think they have POTS because they've read about it. And sometimes we'll check orthostatic vital signs on them, and sometimes they do have a drop in their blood pressure with standing. And as you know, some of them have other issues on top of an infection, like they live in a house where they're sensitive to mycotoxicity, which I know that I lose some. I know I definitely lose some conventional doctors when we start talking about that, but there's definitely a subset of the population that is very affected by that, and they have a lot of disequilibrium issues, and
Mm.
um, I think some of that is dehydration. I mean, if you deeply read, some of the hormones affected by mycotoxins will have an effect on like how the body retains fluids.
Right.
And if you even drink a lot but you don't hold on to it well, that can leave someone feeling fatigued and
Mm.
off balance and weak. And
Right. Right.
so,
And anemias, low platelets, maybe low hemoglobin hematocrit, or history of low B12. These are all various either findings or hypotheses. Do you find any consistent or somewhat common findings here with anemias?
definitely if someone's got Babesia, if it's fairly advanced, because Babesia is a parasite that infects the red blood cells. You can see some anemia, although I see patients often with Babesia that are not anemic. I find that the usual workup for a lot of the ambulatory patients, let's just put them in that category. So the ones who have a mild to moderate case, who are still working, but maybe not feeling well and starting to feel decline in their health, a lot of their labs are going to be normal, you know. Um, and when I say their labs, I mean like the general
Blood work.
wellness panel
Yeah.
from Quest or LabCorp. But if somebody's already in a wheelchair, on a stretcher, like they have to be walked into the office, a lot of them are a little anemic. Their platelets might be high or low. Their liver functions might be high. You know,
Yeah.
I like there's a possibility for all of those, I think.
Okay. For our audience being gut nerds, gut health connoisseurs, if you will, are you seeing Candida as something that sort of co-occurs? I know assessing and quantifying Candida isn't super definitive. There's not great diagnostic criteria or normalization across what markers we should order. But thinking about chronic infection, immune system suppression, and that Candida is opportunistic in that sort of environment, it makes sense that we would see a predilection toward Candida overgrowth as opposed to something like SIBO. Any read on this?
Well, since I do treat patients with antibiotics sometimes, I'm definitely really watching out for having secondary issues with yeast. In fact, if I can see that the patient's already not going to eat properly. So, by the way, can I call you Michael?
Oh, please, yeah.
Okay. Well, so Michael, I see a lot of kids with PANS pandas also, which, because when we're treating a chronic infection that's triggering an autoimmune disease, a lot of those kids won't eat. They have obsessions and compulsions related to food, a lot of food aversions. So sometimes those kids, one of the best things we can do is cover that base with some sort of, anti-candidal, whether it's herbal or prescription. Sometimes it makes a big difference in their behavior because all they'll eat, say, like I had a child in the office yesterday that mostly eats apples and oranges. And not that those are bad foods, but if you eat 10 apples and 10 oranges a day and you're not eating any protein, I even I'll look at their nails, I'll look at the tongue. I even examine their bottom. A lot of times they'll have some yeast, like just in kids, and if I could change the diet first, I would, but sometimes it's just not possible. So the answer to that is yes, I look for that and I do see that. And I think that's one of the biggest negatives for the current American diet is just so many people have
processed carbs.
I mean, we've fed the machine, or fed the monster, I should say, for a long time.
Right. Yeah. And it's kind of a perfect storm, right? Early antibiotic use, maybe more cesarean. I mean, if you have to, you have to, but cesarean birthing, formula feeding, stress, high sugar diet, all these things are going to coalesce and not put us into a good position regarding Candida. Do you have a way that you like to assess this? Stool, diarabinitol, blood antibodies, something else?
No.
I appreciate the candor.
To me, it's mostly clinical. I'm just in the process of starting to send some stool samples out to Progenobiome in Malibu. Dr. Hazen has become a friend. Like, she spoke also at TFIM. I don't know if you know her, but
I don't.
She would be a wonderful person to connect with from the angle of just, I think she has the biggest stool microbiome bank in the United States. And she she's actually doing DNA analytics on the stool. And then when she's using it in interesting ways, like she's using an IRB, going through like the FDA steps, which cost, as you know, a lot, but to do some research for kids with autism using fecal transplants. And she's, had some case reports in the literature. She's got actually a lot of published articles on PubMed, and she has the Malibu Microbiome Conference, I think, is coming up in August, and she's done that for a few years. She speaks at ILADS a lot, which is how I got to know her as well. And, I've played around. I have definitely used some of the different commercially available stool studies out there. I find them not to be super consistent. Honestly, the older I get and the longer I practice, the more I just ask the patients more questions and try to sort it out that way.
Yeah.
And then go with what makes the most sense from their history and their current symptoms. I mean, so many people with reflux, they just have yeast overgrowth. And so like, I'll try it, I usually know fairly quickly if we're on the right track. But I've had patients with chronic abdominal pain have complete resolution of their abdominal pain by just putting them on something for Candida. So it's not everybody by any means. Like, that's that's the disclaimer. It's like, one thing does not work for every patient, or else this would be easy. But it does work for some. And I have a high suspicion of it when someone starts telling me that they have reflux, that they crave sugar, that
Loose bowels.
you know, they can't live without sugar, they
Yeah.
itch. You know, so many patients also just have histamine issues. And like I know you see it too. Like you have patients that don't seem to touch sugar that still have a lot of GI problems, probably because their diet is too narrow. And then other people will have a terrible diet and seem not to have any GI issues. Even my daughter, she's like, why does my friend eat so poorly and has like no acne? And I try to eat so well and I struggle with it. And
Yeah.
it's because there's so many other factors involved in
Sure.
that.
Sure. Yeah. And great points. And I'll second what you said about the Candida testing. We've split test a number of different stool tests, either same stool, two different tests, or same test in serial with the same person, looking for consistency. And I haven't been impressed with the consistency. We're currently looking at para wellness and doing some split testing there to see how consistent that is. And pairing that with the blood antibody along with the diarabinitol plus a modified version of the IFM's Candida questionnaire to, just to try to see how, what quantifiable measures can we use. To your earlier point about the Horowitz 38-point survey, we found the IFM Candida assessment also a little bit too long. So we've curtailed that, and we're working some of those same angles in attempts to give people well, maybe you can't do all these lab markers. Here's a symptom inventory that may work well for you. But a lot of work to be done, I think, in the field from a research perspective, which is cool and exciting. I think it needs to be done, and it's a good time for us to be a bit more scientific, or at least try to contribute more to the scientific database. One of the things that Joe Burrascano has said that I think is interesting, he calls ticks nature's dirty needles. And maybe we could also include things like mosquitoes along with that. And they pass around these organisms. One of the things about these organisms that I think is important to mention is many of them, I think most of them, Bartonella, Babesia, Borrelia, Ehrlichia, Rickettsia, they all go back hundreds, if not thousands of years. And I think that's important to mention because sometimes people think, I was unfortunate that I got this bug. And that may not be, and let me know if you disagree, the right way to think about this. It might partially be the bug, but the terrain seems to have a lot to do with susceptibility. What are your thoughts?
No, I completely agree with you. I mean, I have had patients be so fearful of getting sick again once they're better that they, don't camp and they don't fish and they don't hike and they don't, they get rid of all their horses. Like, I'm like, oh no, like, we are intended to be in nature, but we're also intended to be strong enough to have intermittent exposures to these things. I think pretty much everyone gets exposed, especially Bartonella. I mean, they found it in ticks, but it's also flea-borne, and then cats, so how many people have cats in the United States? Like, and the veterinary community doesn't seem to have as much of an issue with looking for a type of chronic infection or some of these infections that can be passed around from fleas and ticks. So I definitely have had that talk with so many patients. Like I want them to be outside. I mean, obviously, like look for ticks after you've been in a place, in the woods or tall grass, and or, wear your socks to your knee. And, there's actually a really good book called Preventing Lyme Disease that I tell patients to get. But I also got to speak recently at the European ILADS conference, and I was looking for some pictures of ticks in nature just to put, slides are better if you have a picture. And ticks are very hard to photograph because they're so little. Like, I found a lady that had some videos, and she had just gone to some parks and did some very interesting close-up video under like the park bench arms, like the end of the park bench, where there's just like a little bit of webbing, and then there's a little cluster of ticks. And patients tell me that a lot too. They're like, I don't think I've ever been bitten by a tick. And And I have been bitten by ticks. I grew up in the country in Northeast Texas, and we played outside barefooted and climbed trees. And um, I don't think that Lyme disease was as prevalent back then. I think it has kind of spread across the U.S. But one of the biggest vectors I think that goes unappreciated is birds.
Mm.
They're really disgusting, but there's some pictures on the internet of birds carrying ticks. Usually it's kind of around the eye. But even that book, Preventing Lyme Disease, talks about if you have a birdhouse, put it at the corner of your yard and not in the middle.
Ah,
Just, I know it's little subtle things, but I don't think the fear of getting bitten should prevent people from
yeah.
enjoying the outdoors and getting out in nature. I think what you said earlier, building up the immune strength, building up the digestive health, building up just resiliency is it's the way to go.
Yeah. And also thinking about the pretty impressive data showing that those who spend time in nature, green zones or blue zones, have a lower all-cause mortality. So,
Hmm.
the net impact must be healthful for being in
Hmm.
nature.
I 100% agree. And I tell people too, like think about a hiking guide at Acadia National Park. He's outside all the time, and he's completely,
Right.
he might have an occasional acute illness, but the other thing, I think people have started to think acute illnesses are bad. And really acute illness is where we get reminders to be immune and resilient to infections.
Mm.
So if we get the flu once every few years, I think that is normal. Um, but I think even parents, I have friends who are grandmothers now for the first time, and they call me in the 10 o'clock at night. Oh my goodness, my grandson has a fever, and I'm like, okay, well, is he eating? Is he drinking? Yes, but should we
Right.
take him to the ER? No. I don't know where everybody's afraid these days. I think that's also catabolic for health. And
Agreed.
I
Yeah.
just don't know how to overcome it always, but more education.
Yeah. And I
Um,
think the framing is important. That's why I ask these questions because, as a clinician, you speak with people and some people are just so fearful. And so I think it's important for healthcare providers to educate, but then also give the appropriate context so that people don't tip
mhm.
across the event horizon to an excessive amount of fear. And, as you're making the remarks about the hiking tour guide and the acute illness, it reminds me of something that Moises Monoff Vasquez, who wrote the book Epidemic of Absence, which sort of chronicles how we need exposure to bugs to have a healthy immune system. He theorized from all his research and observations that there tends to be two ways the immune system reacts. One is hard and fast, and these people might be more prone to autoimmune conditions. And the other is they sort of get along with the microbe. They don't have that robust immune response right out of the gate, and they sort of allow it to be there to a small extent. And then, the other approach is really hit it hard and fast. It was just his musing, but maybe different people have different ways their immune system handles these bugs. And maybe it's the latter camp that are more prone to some extent to develop these chronic infections. I mean, stress and other things are probably the larger part of it, but just an interesting thought you gave me from Moises' book.
Well, it's interesting. A lot of patients, when I ask them about what was going on when they first started to feel unwell, a lot of them were training for a triathlon, or they
Mm,
were, a new partner in a law firm, or they were, like really um exhausting themselves
yeah.
for something that might be amazing. And so and I don't want them to stop doing those things. I want them to figure out a way to maybe focus a little more on recovering
Yes.
and sleeping, but not to stop being active just because it set them up to be more susceptible when they got exposed to one of these infections.
Well, I'm so glad you said that because that's one of the lessons I've recently learned is that, I used to use intense exercise as my stress coping mechanism. And I'm learning you've got to have somewhere where you go parasympathetic. So
Hmm.
for people out there, when you're a new partner at a law firm, let's say building upon your example, may not be the best time to also try to be optimizing and improving your fitness levels. Maybe wait until you're through some of that onboarding.
Well, it's there a lot. It's the type A's a lot of times that end up suffering through these things. And I at the risk of sounding, I don't consider myself necessarily hyper religious, but I definitely believe God is in charge of my life and directing my steps and my calling. And I use that quite often as a way to have some parasympathetic tone in my life. It's like I give it over. I lean on that as a way to not always be the one that's in charge of everything, because I can go there fairly easily. And most of us, I think that our doctors, we've spent a lot of time in school. We've definitely stayed up late cramming for exams. We've, been in stressful situations, and been sleep deprived. Like I had some pretty severe sleep deprivation as a resident. And I don't think that was good. I'm so glad I didn't get tick bitten during that time, because I don't know if I would have been able to overcome it. But especially if I have a patient who's recovered and now they want to go back to, long distance bike riding, or some sort of vigorous, physical activity, or something where they're going to travel a lot. Like I've had a couple patients that travel internationally and they're always changing their sleep wake cycles. I'll just try to really help them make sure that's important, and to not let themselves get run down and become vulnerable again, because I think that vulnerability is a huge part of relapses.
Yep.
So when
Yep.
people relapse, we can usually piece that together again. Or what I like, now that I've treated people for quite a while, I'll tell them the minute that you start to feel recurring symptoms, like don't wait. We want to, you don't have to treat them nearly as aggressively if you catch a relapse early than if you wait again to see if it's going to get better on its own. So just education again, so they can take care of themselves.
It's the same sort of analogy we use with our digestive health patients, wherein there might come a time when there was a destination wedding and you were in Greece for a week and up late and drinking. And then when you come home, you start to feel like things are regressing. Well, if we've learned what worked for you in the past, step one might be, okay, retightening to an elimination diet or a low FODMAP diet, plus a clinical dose of probiotics, whatever the things were. And sometimes just having that, as you said, that education, that information about what your system needs to get you back on the straight and narrow goes a really long way.
I agree.
Yeah. What were the three, I think you said there were 3 immune markers that the lecturer way back when had recommended? I'm assuming one might be CD57, but just wondering what these are, and are they things you might recommend? Let's say someone listening to this is saying, ooh, this sounds like me. Don't have a good doctor locally, but I'd love to do maybe a direct-to-consumer panel and just get a sense for, should I traverse further down this path? So what are the markers, and do you think people can do them on themselves for at least a initial poke into if this is something to think about?
So it's funny, Michael, that same lecturer about 10 years later was making fun of people who used those markers.
Well, I appreciate him being like self-critical, right?
I went to him at the break because I actually know him. I did my master's in integrative medicine through GW, and he was one of the professors. I got to know him through that. And so I went to him, I said, hey man, you're the one that taught me though to use those markers. He's like, I know, but like we've kind of moved on. But you're exactly right. So CD57 was one of them. Which I did use that for a season. I just found it's a very slow recovering marker. So like the patient may feel a lot better, and you check the CD57 and it's only come up 20 points. And then they're like, oh no, I'm not better. And I'm like, no, you are better. You were better before we looked at the lab test. And then the other two, which have gotten prohibitively expensive, and one of them has to be on dry ice, and it's challenging to order because it's just crazy expensive, is a C4A. So it was a TGF beta 1, a C4A, and a CD57. And
Gotcha.
but I did use that for a fairly long season as sort of a screening panel for patients, and I did find that when those were all out of the normal range, CD57 low, C4A high, TGF beta 1 high, the patient usually was infected with something or had mycotoxicity or both.
Mm,
And so, I don't use them as much anymore, mostly because of expense, and insurance used to pay for C4A, C3A, TGF beta 1, that whole kind of shoemaker panel,
right.
the MSH and the VIP. And then all of a sudden it seemed like that all stopped. So again, I really lean heavily. I usually spend like 2 hours with my new patients and about an hour on my follow-ups, because I really put a lot of the weight of my decision making on what happened to them, what their symptoms are, what they've responded to, what they've tried, what didn't work, what did work, and sometimes it's the hardest patients are the ones who don't have anyone with them to help, and they have some cognitive issues. They don't really
Yep.
remember what they've done, and they don't feel well. I mean, those are the tough patients to help,
Mm.
but we still try. So,
Well, I agree with you so much in the sense that their history, their symptoms, what they've done. And in fact, we have a couple tables in our paperwork of different diets. I've tried it, I haven't tried it. It was helpful, it wasn't helpful. I had a reaction, various treatments, just as sort of an initial prompt, because there's so many valuable breadcrumb
mhm.
clues scattered throughout their history. So you also kind of answered a question I wanted to ask you, which is, do you think you could succeed in improving someone's health who you suspect has Lyme or a co-infection without any testing?
So I like to do some testing. I mean, there's a handful of reasons. Number one, it sometimes helps narrow the focus a little bit.
Mhm.
It shows the patient they were exposed. I mean, antibody testing really just says someone was exposed. It does not tell me that that's what's really causing their problems.
Right.
Um, and and to me, the testing is secondary to the clinical picture. It's not the other way around. And I feel like that's the challenge in like in teaching, because I have I'm part of the faculty for the physician training program through ILADS, and I'll have people call me or send me labs and say, "What do you think I should do for this patient?" And they just send me the labs, and I'm like, the labs are the supportive information. They're not
Yeah.
the diagnostic therapeutic decision maker. Um, but I do sometimes have patients that I have to start with something, and they literally do not have the resources, the financial resources to do the testing. Um, and so, I'll use like some of the things I use are, and just to get started will be like, um, can I say brand names of
Oh yeah.
things?
Anything is within
Okay.
bounds. Yep.
Um, so I'll use like an Allison product like Alamax Pro.
Hmm.
I've used a lot of liposomal cinnamon clove oregano. I'll use
Hmm.
liposomal artemisinin. I'll use cryptolepis, which now I've found that in a capsule. I used to have that in a tincture, and the main complaint I would get with it was it didn't taste good, and it gets
Right.
expensive it does get expensive when you start increasing the dose. Um, and a lot of times I'll combine those. A lot of times I honestly don't even use those at the beginning before I get to that sort of treatment step. Um, I want to sort of prepare the patient for tolerating treatment. So giving them, I use oral immunoglobulin a lot. Like SBI Protect, or like there's a handful of different ones. Aloe helps. There's kind of a cool product that I think Jim Laval formulated called Rebiosis. I don't know if you've ever played
No.
with that one.
No.
It's got, I think, cat's claw and berberine and grapeseed
Mm,
extract in it.
mm-hmm.
And it's all in one pill. So, I mean, as you know, when I'm selecting a therapy for a patient, I can't give them 58 pills in the morning and 58 pills at night the first visit. So, trying to align with what their priorities are to start. And then teaching them, I tease patients and say, some people need a nudge to even start a treatment. And sometimes that's because they felt terrible in the past when they started something too aggressively. Other patients want to do everything right now. And maybe they need a little bit of uh, anabolism first. They need a little, I use peptides in my practice. I use sometimes oral, sometimes injectable. Sometimes they need to just get to sleeping better and digesting better and getting in like the very basic things before we start using antimicrobials.
Yeah.
So, it's kind of a step by step, but those are some of the ones that I don't usually give patients a lot of antibiotics if I don't have a test to justify it. That's other
Understandable.
place where
Yeah.
that's just sort of like a medical legal issue. If I have a test that says, okay, this patient's been very exposed to tick-borne relapsing fever, Borrelia,
Sure.
Bartonella, Babesia, even if I'm not 100% certain which one, I feel a little less hesitant to give them, you
Right.
know, more antibiotics. So, and sometimes antibiotics is where we get to. I don't necessarily love it, but sometimes it is, even IV antibiotics. I had an interesting case referred to me from a rheumatologist in San Antonio. He saw two sisters that both had been like very accomplished high school athletes, and both started having a lot of digestive issues and joint pain and brain fog, both very intelligent too. Um, and, and their dad took them to a rheumatologist friend of his who gave them, put PICC lines in them and gave them Rocephin for 30 days because he thought they had Lyme, and they felt completely better. But then
Mm,
as soon as they stopped the antibiotics, their symptoms all started coming right back.
yeah.
So even their gut symptoms like that, I was amazed, you would think an antibiotic would cause problems with their digestive system, but I do think that these organisms do have, for some patients, a focus that's digestive.
Sure.
And so it's just figuring it out, and it's hard sometimes, but
Yeah. Yeah. I mean, I guess this is the art of clinical medicine. And one of the things I think about, borrowing from what you said, is if we're too aggressive too quick, then people, firstly, they may relapse because you didn't fix the underlying lifestyle issues that are weakening the immune system. Um, but there's also, there's different perspectives I've heard on this, which is one is you want to hit these organisms kind of hard and fast and thorough, meaning having an adequate duration of treatment so that you don't partially clear the infection and allow persisters to propagate. And I think that makes sense, but probably best in the context of, let's take the high school athletes as an example. Maybe they're training really hard. Maybe they're
Mhm.
drinking on the weekends, kind of like partying too much, not sleeping enough. So that paradigm of thorough treatment may need to be sort of phased until after you've gotten them eating better, not
Mhm.
drinking as much, recovering. And then when you do the treatment, you want to be adequate. Because I've seen, I don't work with a ton of Lyme cases, but I've seen enough where the philosophy we use with GI is minimal effective intervention. And I don't know that works the same with these chronic infections. I think you want to be a little bit more robust. I know there's a lot there kind of untangled, but how do you think about this?
I think that's very individualized also, because if somebody, I've had a 10-year-old in a wheelchair come in that was so sick that she could go to school.
Hmm.
Her mom quit working to stay home and take care of her, and she'd been to so many specialists, and I don't think any of them had ill will or weren't trying to help, but literally they just were not hitting the mark. Um and it's hard to get a IV line in a 10-year-old without like causing red flags. So sometimes there's other considerations like and a lot of times orals really work. But what I do, I introduce one thing at a time, but as soon as I know it's well tolerated, I will stack the next thing within 5 days or 7 days, sometimes 2 weeks depending on what it is. Um and I am with someone who's really ill, I will definitely be more aggressive. It's just a matter of can they tolerate it or not
Yeah.
too, because
And sorry, when
sometimes
when
if
you
they
say, not to cut you off, but when you say tolerate, I'm assuming it's a degree of die-off. And if so, are you looking at some degree of die-off as a positive signal that you're on the right track?
I tell patients if you don't feel well for a few days when you initiate a new therapy, but you can tough it out, let's do. versus like you have nausea and vomiting that's just nonstop, or an intractable migraine. We stop. That's why we have so many substitutions. Or just maybe go a little more gently, on board. But I do it. I would say the way that I would call it more aggressive is I try to get where I'm going a little bit faster. And not give them one herb and say, I'll see you in 6 months and hope you
Right.
feel better,
So you give them a list, and is it something like, here's 5 options, try to work on to at least 3 of these that are tolerated?
A lot of patients I see have already tried, they've already maybe tried doxycycline, maybe they've already tried, none of them have ever tried cryptolepis or artemisinin usually. But they might have tried some
Oregano.
cloves or something, and I don't think that there's any, patients also bring me their remedies and say, hey, Dr. Aby, this works really well. And then I'll have to go like look into it. But, doing things for inflammation and support, like sometimes I will use disulfiram in some patients, which is a really old drug. And I have supplements specifically alongside that so patients tolerate it better. And what I mean by that is like the big 3 side effects are fatigue, sometimes neuropathy, and sometimes really significant mood issues. So rather than wait till they have those and want to stop treating, I give them a few supplements to try to offset those at the front end. And then that's where sometimes using IVs in the office, like even IV hydration sometimes just makes people feel a lot better and gets them through those first few days of maybe having a die-off type feeling that they don't like.
And for some of these more challenging cases, I'm assuming something to address biofilms, serrapeptase, lumbrokinase, nattokinase, maybe even methylene blue, which seems like a really interesting compound. You have to be, careful. You have to do that G6PD test first. But are these an essential part of the cases that have not fully responded in the past, and you're suspecting some biofilm or some persisters?
So I have used all of those in certain patients. And I'll just say that again, it like, for instance, serrapeptase is supposed to help more with pain. So I might choose that one over, say, lumbrokinase, even though it probably is not as strong of a fibrinolytic. But then I even have patients that take it and we max out the dose and they say their pain is no different. So then it just comes back to like trying to figure out what's going to work for that patient. But I do think I add those usually a little further down the road once we've, I don't really know if this is true, but in a circle of colleagues at a meeting, someone said that they don't use anything for biofilms until they've at least cleared what's easy target. So, that kind of made sense to me that if I start someone on an antimicrobial, kind of clear what's susceptible to it, that's maybe more exposed in the circulation or the tissues, and then start adding something to break up the fibrin, maybe after they've improved, then they'll probably potentially tolerate it better when we get to that step. I don't know. I think I do it that way because it made sense to me, and it does seem to help patients. I do have some patients that come in and they're already started on lumbrokinase, for instance, and they're not feeling well at all. And so then they don't want to take it anymore. And so we have to kind of go back to what is it for? When do you take it? And the sequence of taking things matters a lot too. I know that I'm sure that you feel that way too about digestive restoration. Like the sequence with which we take things makes a very big difference.
You mean in a day, or I'm assuming you mean sort of like phase 1, phase 2, phase 3, like diet, lifestyle, GI first, and then microbes second. Yeah.
Yeah. And patients also will say things like, you always treat mold first. No, I don't always treat anything first. I try to figure out what might be the most helpful first, and that may be different for each patient. I don't always treat Bartonella first or always treat Babesia first. I kind of try to figure out what is the most problematic, symptomatic infection and work in that direction usually first. I mean, I like to treat Bartonella early because I feel like the patients get the most results from treating that, those infections. Right. And a lot of times there's a little bit of overlapping of the antimicrobials that cover some Borrelia as well.
Especially the
And
naturals. Yeah. The
yeah.
natural agents. Yeah.
Hmm.
And how are you quantifying that? Because I guess part of this can be adjudicated based upon symptoms, but I'm assuming in a number of cases you're doing some sort of objective lab markers. IGeneX seems to be popular. T Labs seems to be popular. Can get kind of pricey when doing these tests. You're looking at maybe $4,000. So, I mean, for your health, I think that's a small price to pay to recover it. Sure, but different people have different financial means. But yeah, what tests do you like?
If I could do, there's pros and cons of each. Like T-Lab is a nice test because it's a direct test. So we're looking for the actual presence of the microbe in the blood of that patient. And you actually get a picture showing that the probe is showing the presence of the organism,
Right.
which, in just practical logical thinking, if that was eliminated and the patient also clinically improved, I would feel like that's a good way to sort of quantify, I think, or I don't even know, qualify probably is the better word, but versus antibody testing, which, I've definitely used IGeneX, I've used Vibrant Wellness, I've used almost every lab out there, except some of the European labs. I haven't used them very much because it just adds to the expense too. But I don't usually test antibodies and apply that very strongly to the patient. Like if someone still has high antibodies towards, say, Borrelia, but they feel a lot better, I'm gonna use the fact that they feel a lot better as my marker more than I'm gonna use the
Right.
test. So if someone's feeling a lot better, I don't always do a follow-up test. But if someone's not feeling better and the test is going to change what we're going to do, that's when I'll think about ordering it. But I've used all of them. And then, the thing that IGeneX has that's nice is a larger panel. You can, like T Labs, you can only test at this point for Borrelia burgdorferi, Bartonella henselae, Babesia decoyle. They just really recently added Babesia species, which,
Mhm.
like, I'm going to probably quit ordering Babesia decoyle and just order the Babesia species one, because if I know the species is there, I'll know how to approach the treatment. But that's really all they offer. So I'm not going to pick up TBRF from those labs. And sometimes I'll have patients where, kind of like you were talking about split samples, they want to, they say do everything that you can to figure this out. And I might order from two different labs and then compare them. And that's always really interesting because, you know, the nice thing about like Vibrant Wellness, even though there's some critics out there about the test, it is more affordable than some of the other tests. It may be overly sensitive, but if I look and see that they have antibodies to a particular pathogen and that makes sense in the clinical context, it's at least something that I can put in the record that
Right.
kind of justifies the approach.
And with your approach, I know that in your clinic you do IVs. In fact, I've popped over to your clinic and done the 10 pass IV ozone, which I think is a really interesting therapy. That the more I study it, the potential to kill microbes, to stimulate stem cells. So yeah, would love to get your overview on IVs and which ones you think are worth consideration.
So I started doing IV therapies in my practice about 11 years ago. And of course, the first thing I started with was just IV vitamin C and, Myers cocktails. I went to a class, learned some basic IV approaches, and even those IVs make some people feel better. I will still give someone IV vitamin C if they have acute illness. In fact, at our clinic, we treated over 6,000 COVID patients, and a lot of them got IV ozone, IV vitamin C, and IV glutathione. And I think it helped. So I don't think IV alone is ever enough to get someone well. I look at it as a more of an adjunctive treatment that might help them need oral therapies less long, or you know, just to complement whatever else we're doing. But we have added to our IV therapy list quite a bit. I actually really love IV procaine for mast cell activation patients. So patients who are really, really sensitive to everything and kind of can't take. I mean, I've had some patients say they can't even take vitamin D. Um,
And sorry,
and
is that mainly for pain or is it just for reducing reactivity globally?
I have a really good paper that I'll send you
Mm,
that talks about all the benefits of it. It's a little bit of an outlier in the class of the cane family of anesthetics. You wouldn't get the same benefit from doing IV lidocaine necessarily, although I do know some pain doctors who creatively use that in patients with like complex regional pain syndrome and things.
mm,
Um, I wouldn't, I don't think I would give IV lidocaine in my practice, but I have some good protocols for the IV procaine. We give IV ALA for people with non-alcoholic steatohepatitis, and I find that like I got that protocol from a doctor in New Mexico who's been doing that for years and years and has some published data on it. He was very generous to share um, his experience and his protocol with me a few years ago. And so we have a protocol for non-alcoholic steatohepatitis or NASH, which is, I think, affecting now like 25% of the US population.
mm.
That
Oh,
the core of that is alpha lipoic acid IVs, which you do have to monitor a patient's blood sugar and kind of monitor their vitals. But I've been watching and I think it's making a big difference. It also seems to really help neuropathy. Um, so some patients that I've used it on for fatty liver end up having improvement in their neuropathy too. So I think that's been a good side benefit. The IV ozone, like I developed the interest in ozone because I learned about it through some of the other colleagues who were treating chronic infections. And again, like I like to look at things from a practical level. So um, we don't have a lot of US literature on ozone, but all around the world, there's a lot of European literature. And even like Sylvia Menendez from Cuba has a textbook about all the different applications of ozone medically.
mm.
I've heard her lecture. I've gone to some conferences and learned that it's just not taken hold, I think, because um, it's not a drug. And it is, I mean, a lot of my patients actually use non-IV ozone. They do rectal insufflation or vaginal insufflation or ear insufflation, or even sinus insufflation. And they think it's been a great addition to their like toolbox for staying healthy.
On rectal, I was a little bit skeptical, and this was only a quick poke into PubMed, but there was two papers in COVID that found that rectal insufflation was helpful, not for reduction of mortality, but for a number of inflammatory markers, and I think for maybe O2 saturation. So at least there's something published showing that rectal, because the main thing I was wondering is the absorption adequate to have a clinical effect. And, apparently it is, which is nice because people can do that direct to consumer and just get a home setup.
Yeah. Well, it's anecdotal, of course, but I have some friends here locally who two families split an ozone generator between the two of them. They bought one together, and one of their teenage kids is using it for acne and swears it's just the rectal insufflation has just resolved his acne problem.
Hmm.
I didn't even think of that. Like I have access to ozone, and like I haven't really recommended that. So
Right.
patients teach me too, and
Yeah.
and I'm not saying that's everyone's acne cure, but if it's actually very safe, and it's I think of it as like a natural cleanser. That's what it's the smell after a thunderstorm. It's like lightning in a box is really what an ozone generator is. A coronal electric current that excites the oxygen atoms and causes them to basically separate, and a large proportion of them will restabilize into paired oxygen. Um, I heard an estimate of 96%, and then about 4% will temporarily restabilize into groupings of three, which is what ozone is. It's
Or
O3,
three. Yeah.
which has such a different behavior than O2, um, more like more like bleach, except we would never put bleach in someone. in an IV. But if you put oxygen in someone and the consequences of that are lipid peroxides, maybe peroxide would be a better analogy. Some people do IV peroxide. I don't do that at my clinic. But it makes sense. I mean, we put that on cuts and wounds so they don't get infected. We clean things with peroxide. So when you're trying to knock back a burden of infection or bacteria, viruses, unwanted fungal elements, like it makes sense to do something to kind of clean the blood. I know that's not very medical or scientific exactly, but
maybe
that's
to
kind of
pick
how
up
I
on that,
explain it to patients.
is the way you think about this. I've heard it described as we create oxidation with ozone, and we have endogenous antioxidant defenses, so we can buffer that oxidation. Microbes can't. So it's kind of a 2-for-1 benefit. One, you oxidize and help the immune system kill the microbes, but also that oxidative stress improves your own ability to release more antioxidants.
And vitamin C is very similar. Like a low dose of vitamin C will just diminish vitamin C in the face of a sickness or a lack of intake. But if you start pushing those doses to higher doses, it does become more of an oxidative dose.
And that's over 20.
From which
over 20 grams.
I've heard 40, I've heard 25,
Okay.
and in our office, we'll give over 25 if we have a G6PD on file for that patient. Some people go up to 40. I don't see a huge difference in benefit between 25 and 40, to be honest. The only patients that we'll usually go to, say 75 or 100 grams, obviously they need to have a G6PD test first, but will be someone that's trying to follow one of the cancer supportive, like adjunctive protocols. I don't usually do that in my infected sick patients as much, but
Okay. What about hyperbaric oxygen therapy? Not hyperbaric ozone, but getting in an actual chamber. The direct-to-consumer chambers are 1.3 atmospheres, maybe 1.5. The medical is 2. As I've looked into this, there was that one study. It was a sham versus intervention, and I think it was 2 atmospheres with 100% oxygen as the treatment. And then the sham, if I'm remembering correctly, was just room air at 1.3 atmospheres, but both groups showed cognitive benefits. So they kind of were trying to disprove, and they proved, which is fine. It's part of the scientific process. But do you fool around much with hyperbaric chambers, and what do you think about them?
I had one in my office for a short time before I found ozone. And I liked it. I think it works better if you're going to go through a series of dives. I think it's good, to use as much oxygen and pressure as you can tolerate. In fact, I have a patient that I'm treating right now she's going to ATX hyperbarics over in Austin. And I think maybe today she might be getting a tube in one ear because she just can't, can't increase the pressure because she's got an ear issue. So she was seeing her ENT today to maybe, they can apparently put tubes in your ears in the office now, like for things like that. But the one that I had, it's so interesting. So mine was 1.3. I did pipe some oxygen into the chamber to get it up to about 35%. Obviously you can't it's meant to be used at home. So it's very safe. And
were they breathing 100% O2 at the same time?
No, I just, the unit that I had an actual little portal where you could thread a oxygen concentrator, and I just turned it all the way up to 10 liters. So I was just feeding 10-liter oxygen through the oxygen concentrator into the chamber itself the whole time that they were inside. So, from the manufacturer, they say if you were to use that technique, it should be about 35% oxygen concentration in the chamber. So that's where I get that number. But it was really interesting. One of the first patients I put in the chamber, his daughter has been my patient a long time, and he had been diagnosed with Parkinson's, and she wanted him to try hyperbaric oxygen for his Parkinson's. And he didn't say much. He was really just kind of there because of her urging, I think. But the day after, he only did one dive before he called me back and asked me to call him. And I was afraid something was wrong with his ear or sinus or something.
Kind of an
I call
ominous
him
message.
back.
Yeah.
He's a rancher over in Llano, and he said, "Dr. Amy, is it normal for swelling to go away in your feet when you do the hyperbaric oxygen?" And I said, "Well, I mean, I had just gotten it, so I had very little
Right.
clinical follow-up of my own." And I said, "Well, I mean, I guess it could happen." And he said, "Well, I put my cowboy boots on today for the first time in 5 years." So, I'm just
Oh,
thinking, and that wasn't even while he was there. So, and that's, I do think, what are the Olympics allow them to use a no added oxygen 1.3 atmospheres chamber for recovery. And some of the teams do use that. It's not
that's
prohibited.
interesting. So they don't let you
Um,
breathe 100% O2, which kind of hints at the potential benefits that it holds. Interesting.
so I think, I definitely think if someone's not claustrophobic, or they can go to a bigger chamber if they are claustrophobic and get, I refer people for it fairly often, if they're interested in it and willing and they can afford it. Um, and, it just depends. Some people are kind of homebound, or even that guy that I'm talking about kind of had a hard time getting in and out of a soft-sided chamber to get, inside. But he ended up doing like a series of 40 dives, and I think he was really happy at the end.
Hmm.
I don't know. His Parkinson's to me was very mild. He didn't have a lot of physical symptoms. He just had a very small pill rolling tremor in his hand. And that's why his doctor had said he had Parkinson's, and of course his daughter just wanted to bring him in right away. But
Right. Right.
um, I wouldn't claim it to cure anything as much as I think it's also a good adjunctive therapy. And
Sure.
for some people, it makes a huge difference, I think.
Do you find it skews more toward neurological symptoms in recovery?
I don't know, because I've seen some other just kind of, I think it probably helps cardiac perfusion too. Like that,
Hmm.
I'm thinking with the swollen ankles in that patient, I'm thinking maybe he was just a little bit kind of chronically
Angiogenesis.
hypoxic. Yeah.
Yeah.
And he got a little flood of oxygen and it helped him.
Hmm.
I also will say this is interesting. I have a friend whose wife had some serious neck pain, and he's a doctor, but he's not a musculoskeletal type doctor. And he took her to two or three different people for opinions, and she was referred for neck surgery, but she just did not want to do it. So the physical therapist she was seeing said, "Why don't you try putting your neck in a hard collar and getting in the hyperbaric chamber and just do a series of dives, like while you're in a little bit of, lengthened extension of the neck." And her pain went away after, I don't remember if it was 10 or 20 dives, but, she didn't end up having any type of surgery. And obviously, again, these are anecdotes, but how many patients do you know that have had back surgery, neck surgery, and they still have pain and they still
Yeah.
suffer, and they still, some of them are like, "I don't know why I did that." But
Yep.
um it's it's interesting. It's so low risk for potential benefit that, like, I don't know. Have you ever looked at the integrative medicine textbook that was written by Rakel? I sometimes bring this up. I love the grading. It kind of looks like a clock. I use that book to study for my integrative medicine boards. One side is like the level of evidence of the information they're presenting, and the other side is the level of harm. So if something is, maybe it's low level of evidence, but it's also low harm, and maybe that person's already tried everything else. Like, I
Yep.
mean,
Yeah.
I don't need it to be like a high level of evidence always to try it. Versus, like, say it's low level of evidence but high risk of harm, I'm probably going to stay away from that.
Right. No, I love that juxtaposition. It reminds me of another axiom, if you will, which is a lack of proof isn't disproof. And I think that's important for people who try to look to the
Hmm.
scientific evidence. Just because there's a paucity of data doesn't mean that a therapeutic may not have potential, especially if it's low risk or low cost. And that's the other thing too, is some of these lower risk are super high cost, but hyperbaric
Hmm.
oxygen, isn't terribly expensive. Maybe $100,
No.
$200, I think, per dive. If you buy a package, it's probably less.
Yeah. No,
So
I think it's worth at least exploring it. Mhm.
cool. Well, Amy, this has been a phenomenal conversation. Where can people track you down if they wanted to follow your work or connect with you?
So I have a practice in Marble Falls, which is a short distance outside of Austin, west, in the Texas Hill Country. And we actually, like, I don't know if I can say this on your podcast. I'm looking for more doctors who are like-minded. I can't teach them to care, but I can teach them like how to address patients.
Sure.
Um, and so, I still stay very involved in ILAD. So if anyone was really interested in learning more about treating chronic infections, we actually get to have our annual conference this year in San Antonio, in November. I think it's going to be great. We're working on putting together a really nice speaker list, and I can't wait to meet you in person too. Um, and so, it's just, I think the whole reason for participating in that is to grow a bigger network of doctors who can recognize and treat patients from a more comprehensive angle, earlier. And in Texas, I think we're lacking, for sure, but hopefully we'll just keep growing.
And sorry,
Yeah.
any closing thoughts that you want to leave people with?
I think that what comes to mind is it kind of circles back to something you mentioned earlier. I think a lot of patients are trying so hard to figure out what to do for themselves that it causes catabolic stress. I would just encourage people to find somebody to work with and then
Yeah.
hand over the decision making to somebody that can, participate in it, but don't like, I actually have a good friend right now who's abroad getting cancer treatment. And I was trying to tell him, I feel and hear and see in him like this huge desire to fight the cancer. And I feel like that's tearing him down and making him tired. And I
Yeah.
just said, I don't mean give up by any means. I don't mean not to care about like the fact that this is happening. But if people could just find somebody to work with, which I know is the big challenge, but find somebody to work with and then hand it over and relax into being treated and being cared for, I think we would see more people get well. And I think it's hard to find that, you know, the medical world these days. I don't want to blame it on anyone because I think it's a lot of different factors that have come together to influence it to be, I call it tip of the iceberg. I think I said that at the TFIM meeting. We're just looking for the quick pill, the quick fix, the quick visit, this, the cheapest thing, the quickest thing. And honestly, that's not where the good stuff is.
Yeah.
So
Yep. That's great advice. What I say and we say in the clinic is we will worry on your behalf. And that's
mhm.
important, right? We'll take the notes. We'll study your history. We'll study your response. And then you can do something else rather than searching every symptom on your phone or fretting. I mean, it is participatory. So the individual should be taking part, but I strongly agree that let someone else lead the charge and just have them own that. So sage advice for sure.
A good example is a patient can call and say, I need a Z pack, which I'm like, well, what's wrong with you? Like, and I think that's kind of where we've gotten to a little bit. And I think it wastes a lot of effort, money, time, energy, when we could distill it down and then kind of restore that expert. I'm not saying I'm the expert, but I'm just saying if you find somebody that you can trust and lean on, who cares about you, is going to work with you, and then relax into it, your healing potential opens up because you're not in fight or flight or victim mode, which keeps people sick.
Yeah.
So
Love it. Love it. Well, Dr. Amy Offutt, you are a wealth of knowledge. Really appreciate you taking the time.
thanks for having me.